Hello everyone, I'm Dr. Miskat Aziz from Bangladesh. Today we are going to discuss about microvascular complication of debilitating, life-threatening and chronic disease diabetes. So what is microvascular complication? When any complication occur due to the microvessel is called microvascular complication. Simple definition. There are several microvessels in our vital organs like eye, kidney. So when these get affected, it presented to us with microvascular complication. Duration, susceptibility are important factor here with glycemic control. Broadly, we can divide the microvascular complication in three categories: diabetic, retinopathy, nephropathy and neuropathy. So let's begin with the diabetic retinopathy. Diabetic retinopathy presented to us with complaints of blurring of vision, loss of visual acuity, sometimes they say blind spots or black spot, and this is the early presenting sign when we have to evaluate the patient. The evaluation of the patient can be done by ophthalmologist by testing the visual acuity, doing the direct ophthalmoscopy or even indirect ophthalmoscopy when there is opacity in the media like cataract or vitreous hemorrhage or glaucoma. Fluorescent dye angiography is also done. Sometimes retinography is also done to draw the image of the degree of retinopathy. So retinopathy is a very much common cause of blindness in diabetic patient, which is 25 times higher than the normal individual. It is presented in all type 1s after 10 to 20 years, and some of the type 2 presented to us with this complication already, because the type 2 remains undiagnosed for years in some patient. Retinopathy can be easily managed, but it's very much frustrating for the patient. Some pharmacotherapy is available like aldose reductase inhibitors has yielded variable degree of success. Also anti-VEGF injections are given, but the main prime line treatment of this complication is pan-retinal photocoagulation by laser, and also sometimes we have to do the vitrectomy in case of hemorrhage, severe proliferative retinopathy. Now let's discuss about the nephropathy. Nephropathy is another microvascular complication which lead the patient to the end-stage renal disease. So early detection is very much important. It can be diagnosed very easily by doing some simple tests like serum creatinine with eGFR calculation, albumin creatinine ratio, urinary albumin excretion rate. These are enough to the diagnosis, but the confirmation we have to do sometimes renal biopsy in case of nephropathy in absence of retinopathy with RBC cast in the urine or severe massive proteinuria. Other supporting investigations sometimes we do are serum urea and serum electrolyte to evaluate the other causes, and also the ultrasonography of the kidney urinary KUB region to see the increased echogenicity of the cortex. Almost 40% of the all type 1 diabetes mellitus progress to the nephropathy. Type 2 are less common to get affected with nephropathy, but when we see the end-stage renal disease patient, there is mostly type 2. So the interesting fact is here that the number of type 2 is larger. So we see most are type 2, but it is more common in the type 1. Nephropathy usually treated by controlling the tight glycemic status. Also, we have to control the hypertension with target limit of less than 130 by 80 mm of mercury. Here, the recommended agents to be used are ACE inhibitor or the ARBs, which helps to reduce the proteinuria. Correction of anemia in nephropathy patient is very much important, which we can do by iron supplement, folic acid supplement, and sometimes we need erythropoietin injection, because most of the anemia occurs here is deficiency of erythropoietin. So diabetic nephropathy can be very much debilitating for the patient, which lead the patient to the end-stage renal disease, and it is another culprit that can hamper the daily lifestyle of the patient. So early detection is very much important, and routine screening test is mandatory.
Neuropathy is the most commonly
encountered problem in our chamber among the all three complications, and we cannot cure it, but we can manage it, relieve the symptom. Broadly, it is categorized into two categories, that is somatic retinopathy and autonomic retinopathy. Somatic retinopathy again subclassified into the sensory neuropathy, diffuse motor neuropathy, painful neuropathy with diabetic amyotrophy. Another variation is focal neuropathy. Sensory neuropathy presented to us with hyperesthesia or paresthesia, with burning sensation or painful sensation or pinprick sensation. Diffuse neuropathy presented to us with muscle twitching, weakness of the muscle, progressive loss of muscle power, and sometimes pain. Amyotrophy is presented mainly with muscle wasting and loss of muscle power. It is presented usually unilateral, and it can be cured very easily with tight glycemic control. And another focal neuropathy is like presenting a focal nerve like carpal tunnel syndrome or common peroneal nerve or compression of the 3, 4, 7 nerve pulses or phrenic nerve pulses, like that. So it occurs due to the vascular damage of the nerve called vasa nervosum, also along with chemical damage caused by the persistent hyperglycemia. Other features of this neuropathy is very much bizarre, like burning sensation or pain sensation, or there is cold sensation, broken glass walking sensation, ant walking sensation, different bizarre presentation we see in our clinical practice. Also there is autonomic neuropathy. Autonomic neuropathy presented to us with gastroparesis, that is delayed gastric emptying after taking the food, or also the gustatory sweating, that is sweating during eating, and postural hypotension, variable degree of heart rate, and persistent tachycardia at rest, etc. Also there is erectile dysfunction and impotency in male patients. Around 15% of the patient presented with impotency or erectile dysfunction. So these are the all symptoms we have come to know, and the management we use here. For a small or manageable pain, we usually use aspirin or codeine. And nice recommended treatment for managing the nephropathy pain are amitriptyline, pregabalin, gabapentin, tricyclic antidepressant, others. And sometimes for lancetting pain we also use carbamazepine, duloxetine. For cramping pain in the leg muscle we use antimalarial the quinone. There are some other studies reveal that vitamin B1, thiamine, benfotiamine, mecobalamin, and alpha lipoic acid also plays important role in managing neuropathic pain. And these are the drugs we clinically used to reduce the symptoms, but it is not totally curable. The main aim of treatment of managing the neuropathy is tight glycemic control, good healthy lifestyle, and control of hypertension and other risk factor. Cessation of smoking and alcohol is must. If there is any other symptoms, we have to treat accordingly, and when any patient sees such symptoms, they should go to the doctor for early screening test. Screening test is very much simple and done by the monofilament test, biotheciometer, and also we can do the electromagnetogram, EMG. So if we know the symptoms and we experience any of this in our daily life when we are diabetic and we know that, then you should seek your doctor's help immediately for early detection, because all we know is prevention is better than cure. Best wishes for all. Thank you very much for patience here.